Hi, everybody out there in virtual land. All right, we're going to begin. And today I've got some stuff sort of scattered over the board here, and I'm actually I'm going to do the textbook, the e-text PowerPoint first, and then amplify it. So I've got some sort of generically was writing different things in different areas, and we'll kind of get to all of it on the far board. That has to do with something called a glucose tolerance test, which is even though my handwriting is bad, but I'll walk over there and explain it when the time comes. That'll be later. We'll talk a little bit about hemoglobin A1C and fasting blood glucoses and random blood glucoses and that kind of stuff up there with a 185. And a lot of this is material you're going to revisit again. I guess the jumping off point would be the easiest thing to say is there's no disease that many of you where you're going in clinical and healthcare oriented fields you should know more about than diabetes. It's just if you're treating an adult population, many of you will start. You may vary into elderly, and that certainly would apply. I mean, even with children to some extent it would apply, or pediatrics it would apply. But it's the single most common diagnosis of significance. I mean, outside the realms like arthritis and maybe heart disease, and heart disease very often will be a byproduct of the diabetes. You cannot know enough about it. We could do a whole course in it. The course would not be a one semester course, it would be a year course at minimum. I've gone to conferences, medical conferences, med surgical conferences that were about one topic, diabetes. To understand all that goes on, we don't understand it. It's a syndrome. A syndrome is a compilation of symptoms, signs, and symptoms. Signs, something you can observe or measure, like blood sugar. Symptoms be how you feel about it. Oh, I've got a headache. Oh, gee, I can hardly feel my feet. I feel like I'm numb all the time. I'm losing my balance. Those are sometimes things that you can't necessarily easily quantify. That's the difference. And we go over this. By the way, I do that in micro. If you have me for micro, we'll do the same kind of thing over and over again. So that's what a syndrome is. It's not. And here you're going to see we have effectively two types. We're going to talk about type 1 and type 2. And the mistaken notion that we understand now is so much different that that type 1 isn't just what we used to call it youth onset or insulin dependent diabetes. Okay, the notion was that if it didn't happen by the time you were 40, and typically less, then and then the numbers they give you on this PowerPoint are a little not so accurate. That are there. That it was something called type 2 or maturity onset or non-insulin dependent diabetes. And that only happened with people who were older. And one you treated with insulin and one you didn't. There was so much broad brush stuff that the reality is that we know now that there are a lot of older people all of a sudden become insulin dependent, and the worst by far and away of all of these presentations that we're seeing an enormous amount of, particularly in this country, is what we call metabolic syndrome or syndrome X. It's been around for quite a while. Is we're seeing aspects of what were formerly associated with maturity and not quote unquote non-insulin diabetes mellitus, which is the formal name of the disease. We are seeing that in some degree of abundance in young people. And it's due to we're as a population in this country particularly, let's face it, I mean, whatever your own circumstances compared to people in a lot of areas, we're an extraordinarily wealthy country. Grocery stores that are filled with food. Exactly, everybody's budget and everybody's finances are different, but we have adequate health care, we have adequate food, we have adequate resources. And the trouble is we have a population that's remarkably overweight. If you average out all the numbers, we have a population that has become increasingly less active than more active. We're extremely reliant on these things. As you can see there, we don't exercise individually unless we're more or less forced to. Okay, and a lot of the recreation used to be doing more physical exercise and things along those lines. No, now we're playing video games. So it's a very sedentary lifestyle. Not everybody. There's a lot of people who are just physically active, and I'm surrounded in a room where I look at people who are physically fit. So that is a real problem. We're seeing shockingly high levels of diabetes developing, particularly in that sort of middle school, junior high, high school. And that's a real problem because if they don't get a handle on that, that's going to significantly shorten their lifespan. And a lot of it is it's lifestyle changes and approaches and healthy eating. And if I say nothing else to you, this is something we learned. We learned it. I forgot to mention the other group. It's not again. Some of this. Let me just frame that before I tell you what it is. A lot of the information I'm giving you is contextual and should be interesting to you because you're going to know somebody who's diabetic if you don't already. And somebody, a loved one of yours, is going to be diabetic or is suffering with problems. I mean, the stuff, I'll tell you what you have to know is on that recording that I did. Yeah, glucagon makes the liver break up glycogen and raise your blood sugar. Insulin works on all your cells and lowers it, blah, 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 blah. That type of stuff. We have insulin dependent, non insulin dependent diabetes, blah, and all those. Those are your basic questions from a test perspective. But this is something that you encounter all the time. So I mean, I'm hopeful you'll be doing as much listening and maybe playing this over because you're just going to get more and more information. You can't know enough about that particular thing. But the point I'm referencing is don't lose that train of thought. Years ago, we used to have, they used to rotate, and maybe they still do, nursing through Swickley. Do they still do that through Swickley Valley? They had a physician I knew. It was interesting. Our sons went to an elementary school together, and then interestingly, even though when we moved, they ended up going to Duquesne together. He is, if he's still there, brilliant. He, as a diabetologist, he was associated with the Joslin Center. Joslin's up in Boston, and they came up with a real approach, a very proactive approach for diabetics of any age at any time, and it was very family orbit oriented. You got everybody involved. You had the kids, and you had the spouse, and you had the workplace, making sure that they were active, watching out if they were snacking, what they were snacking on. I mean, you can't do it when somebody, not that I would have ever done this, going to a McDonald's for a couple of quarter pounders with cheese, washed down with a jumbo size, Coke. I would never do that. But that's what they do. And now they've got worse. They've got those Krispy Kreme donuts. I mean, if I take a bite, my blood sugar will raise 1,000. That's all sugar. You understand what I'm saying? So it's a lot being proactive, working on things. Everybody's kind of working with mom or working with dad or the brother or the sister, whoever, to try to change. And they found that aggressive control early is what limited the likelihood of the number one cause of blindness in the United States, diabetes. The number one cause of being on dialysis and or kidney transplantation, diabetes. Now, certainly the number one cause of amputations, diabetes. Just there's a recurrent theme here. So you need to be it's really a condition to be aware of. It's going to affect you personally because it affects everybody personally in some way, shape, or form. Sometimes you're lucky if you did. I told the other group this. I was considered a pre-diabetic. I still technically would be if you're overweight because of the family history. I've been able to escape it for the last nearly 70, don't say 4 years. Don't smile at me like that. Just give me a hard time. She beat you to the punch. YouTube. Okay. So what happened? My maternal grandfather died technically of diabetes. He was very reluctant to take the insulin. So I mean, in those days, that was 1955. People were giving myself shots. My uncle, my mom's brother, who I'm very similar to physically and mentally, for that matter. We were very much the same kind of a person in that way. He got it when he was in his 60s, okay, pretty severely. I mean, all of those things. For some reason, I managed to escape. My mom was not. So I mean, it's hereditarily, it isn't. It's not a distinctive pattern. But I've been fortunate not to, and my blood sugars are consistently pretty much. That's why I drew up here. Whether you do a random blood sugar or even better, a fasting blood sugar. An idea of roughly being, every lab has different normals. I was taught 65 to 110. Even if you had a 110, oh my God. Now, some places, I remember when I was in a hospital, and somebody said, we were taught if you had over 100, you were a diabetic. No, there's other criteria. And I get, and that's why we do it fasting, because you get a better idea. I mean, most people's blood sugar would be well over 110 if they went and if they did a finger stick or any one of the glucometer tests, if they just had a couple candy bars, okay, or they had just ate did that McDonald's thing. Not that I would do that. Look, you get those coupons. It says, buy one, get one free. It's a BOGO. I think it's criminal not to take advantage of that. The fact it was there, I ate it. Not that funny. My parents, people are starving wherever in the world. I took that to heart. Why me eating everything would help them not starve didn't make sense to me at the time, but I like the eating part. This what parents, it's like chew your food 27 times, that type of stuff. I'm a 2-bite sandwich kind of guy. That's why I cut pizza into 6 pieces. I've told you. I can't eat 8. So cut it into 6, can't eat 8. So. God, even Grace gave me a mini smile with that. And you heard that one before, didn't you? Okay, yeah, all right, here we go. So the pancreas, vital, can't live without it. Okay, it's a double duty. When we get to digestive, we're going to talk about its exocrine function. You'll see it. It's tremendously important. And again, we can't live without because we couldn't digest our food. It empties all of this by a duct or a passageway called the pancreatic duct into the small intestine, and it allows us to do digestion and absorption. The endocrine, what we're concerned with, directly into the bloodstream, they're called the islets or islets of Langerhans is the classic way that we describe it. The role of somatostatin is not terribly clear. From my research and readings, to me it suggests, even though it tends to inhibit the secretion of insulin and glucagon, it does so after they have been secreted. And basically what it's doing is it's slowing down growth hormone, which tends to oppose insulin. Not something you have to know or be familiar with, but you're going to see a recurrent theme. When growth hormone is active, utilizing fats for an energy source, insulin isn't. And when insulin is active, growth hormone isn't. That may play, to me, that's where the role is. These two work together. So even typically, okay, and you'll hear me say this again and again, living systems don't make sharp turns. So when you look at that, full of glucose tolerance tests, it's done over sometimes a minimum of 2, sometimes all the way to 5 hours. To expand on it, okay, normally you would see a pattern. Typically, let's say this is 65, this is 100, this is 200. Normally, someone would have a fasting somewhere around here. This is times 0 all the way out to X. Let's say this is 2 hours. Figure so you can see it. And what happens is this. Normally, you would give somebody a test load of sugar here, typically in a very sickeningly sweet drink, like an orange or a cola drink at 20 minutes to consume. Check your fasting blood sugar at times 0. And then within that first half an hour, typically 20 minutes, you drink this in over that first 20 minutes, like say to here. And what it would do is we would see a rather precipitous rise. And then what would happen over time, we would tend to see this. And eventually, by about 2 hours, it would balance out and come back to the starting point. That was a normal utilization curve of glucose. And so this is one of the things years ago, that's how, to some extent, we tried to diagnose diabetes. The reason why I'm giving you this part about insulin and glucagon, as soon as you take that sugar in, your insulin starts to be released. And even though that sugar is rising very rapidly, it shouldn't take much more by about between somewhere the 30-minute and 1 hour mark to peak. and then the insulin takes over. The glucagon actually raises blood sugar because it was just insulin. This is kind of, we would expect a very sharp, living systems don't do that. If it happens too excessive or too sharply, now that's usually a sign of pre-diabetes because very often you're getting unusual peaks very suddenly, and down here, you'll actually fall below a safety line. Anything below 50 puts you in danger because your brain requires glucose. You are much, if a diabetic comes in the emergency room with 700 blood sugar, they're going to get it. It's not a life-threatening situation. Long term it is. You can always get sugar down. What do we do when they come in? We give them sugar. The diabetic, all they have is a bracelet. You haven't had a chance to test their blood sugar, we give them a bolus of sugar. Because what you're worried about is low. You can always give them insulin and get that sugar down and then figure out what's going on and regulate things. But low blood sugar, hypoglycemia is an immediate life-threatening situation. Your brain will shut down and you will die. That's why diabetics, even if they're relatively brittle and high, carry around something that can slip under their tongue or a candy bar, some rapid sugar source. Because that's the one that they start to feel shaky, boom. You don't get it right away, you're in trouble. So this is, and so a lot of times one of the giveaways to someone's a pre-diabetic when you have this sharp turn, it's called reactive hypoglycemia. They eat something and there's like an overabundant release of insulin and no glucagon to compensate for it. So, and we have a lot, and it's not the only system where we see this. There's a lot of biological systems where we see irregularities in sugar metabolism and other metabolism. Even so, if you're in micro, if you haven't talked about it yet, we'll talk about something called the bacterial growth curve. It's a living system. It's bacteria. They're still alive. We don't see sharp turns there either. We tend to do things moderately and gradually. So glucagon, and there's first the insulin comes out. Insulin works on all cells, lowers blood sugar, a variety of other things. And glucagon on the liver increases it. To me, it's like I say, softening the blow. We even do this with certain medications. Years ago, with ADHD, it was the same thing. You'd have this almost like overreaction when somebody would get stimulants, like Adderall, a lot of folks are familiar with. Before they had the Adderall, which is comparatively new, they used to give, different kinds of amphetamine-like substances, and then they would utilize things like Paxil or Prozac, SSRI, selective serotonin reuptake inhibitors. And I asked the physician who was prescribing it, my middle one, doesn't take any medicine now. When he had this problem in his youth, it was like it kind of softens it. We get that reactive when that, it's almost like when that stuff wears off, boom, all of a sudden you get this almost profound hyperactivity, and this kind of softens it. So a lot of times physicians are aware of that in a non-biological or pharmaceutical sense. So don't get me started on that because I think that was always over. Every time a kid didn't sit there with his hands folded and a lot of, and they were rammy. We all grew up like that. This, I know this would surprise you. I had my own chair in the principal's office in detention. It's okay. Oh, I'm checking myself in. You're going to hear about me in about a minute. I know that shocks you. Why is it nobody seems surprised? The obnoxious kid, front row, teacher's begged to be sick and was never sick. He's a teacher. Goes around, comes around, baby. They say life doesn't have its little surprises. And you can read this as well as I can read it to you, and I'm not. Okay, and the same thing. I understand what they're talking about. See, they're talking about what it does, and it's not necessarily like that. Again, this is for general. I'm trying to give you my own, not interpretation's a wrong term. I've spent a career dealing with diabetics. more than half my patients by far, maybe 60, 65% were diabetics. I dealt with diabetics. I told the other class, I've told this before, my favorite patient, now deceased, had no feeling. I remove bone from his ankle that was coming out without benefit of anesthesia. He didn't feel a blessed thing. I had a patient who came in, a man, big, burly kind of a guy. He comes, what's going on? I said, I've got blood coming out of my foot. He was a carpet layer. He was a diabetic. When he took off his shoe, there was a giant carpet tack that had gone through the sole all the way into the foot. We're not talking a little tack. We're talking, like professional carpet layers, boom, industrial. I can't believe it. I didn't feel a thing. Duh. These are things that happen all the time with lack of sensation. That's something that affects the nerves. That's something called diabetic peripheral neuropathy. A lot, 35, I'd say a third to a half, and maybe more, have this. And it's a lot of it. To prevent it is not easy. That's that aggressive management early. Those are people, they'll burn themselves if they have to be careful to have that, or have somebody check the water in the bathtub or in the shower to make sure it's not too hot or too cold, for that matter. Their feet feel cold, they put a hot water bottle on them. Boo! Don't do that. Direct heat's bad. Okay, all of this, there's little do's and don'ts. You'll learn about them. Many of you in clinical fields, because you do a lot of teaching, those types of things. There's so much to it. So the fancy name is diabetes mellitus. Okay, sugar diabetes. You'll hear those terms. A lot of times we would hear, oh, grandma's got sugar. Depending on, you have to understand there's a lot of languages to speak. For those of you going to clinical fields, there's clinical language. This is one of them. Learn what we used to hear about, oh, so-and-so, my sugar's bad. They were telling you they were a diabetic. People had said they had bad blood. Back in the day, that meant they had syphilis. So you understand wherever you're going to be working, whether it's the inner city, whether it's out in the country, there's a certain vernacular to be able to. And when you talk to people, talk with them, not at them. People share more information if they feel that you're listening to them and you're in question and you're really hearing, rather than this business-like, well, what are you allergic to? What medicines are you taking? You're just writing it down. That's the time to, really, my aunt so-and-so takes that. Does it bother you? Have any side effects? No, she gets it. It's all right. Sometimes we have to use the LWL theory, little white lies. Scratch that. I'm like that. What I'm saying is find ways to get people to engage. That's how people. So, all the things I was telling you about, eyes, heart, kidney, that's the nerves. And what happens is, if you can't use the carbohydrates, your body is designed to do this. It uses carbs first. If the carbs are not there, then it uses fats, and then it uses proteins. Trouble with diabetes is you can't use the carbs. Either the insulin is not being produced or produced appropriately, or something has changed, or the receptors on all of those cells are faulty and they can't accept the trigger from that insulin. That's type 1 and type 2, really, if you want to boil it down simplistically. In any event, you can't utilize what your body is designed as your primary energy source, so you begin to use fats. And when fats are metabolized, they have a lot of harmful byproducts. Fatty acids, keto acids, the immense amount of acidity can lead to ketoacidosis. You'll see people in brittle diabetics at 500 or 700, they'll have what's called Kussmaul breathing. They'll be trying to blow off as much acidity, and it'll smell terrible, like they're having a drunk. And a lot of times, you'll get patients who go to jail because they have neuropathy and they can't walk straight, and their breath smells like they were on a 2-day bender. And somebody will put them in jail for public drunkenness, and then they get the test back and go, wait a minute, there's not alcohol here, but boy, there's a blood sugar. It's ridiculous. And they let them go the next morning. It's like, I missed my appointments in jail. I've had that happen. Maybe it doesn't happen so much today. It's a long time. Okay, but you get the idea. And those fats, as you will see, they damage blood vessels. We know that they are a pro-inflammatory agent. and it begins to deposit between the lining cells of the tiny blood vessels called arterioles, which we'll learn about. Where do we find arterioles? We find them in almost anywhere: eye, kidney, all sorts of capillary beds, organs, heart, coronary arteries, basically our arterioles are small branches that go into the heart. Think of all the things where there are the problems: eyes, heart, kidney. Your kidneys are nothing more but a whole bunch of arterioles. Where do we get to kidney? You see all of that. So that's the big problem. Sometimes we do this intentionally. The beauty of the ketogenic or low carb diets, we know this. So if we take away carbs, your body intentionally uses fat. So what do we ingest? Healthy fats. Okay, we drink a lot of water, and you only do that for people whose kidneys can tolerate that. So that's before I went on the precursor of this 40 years ago, which is I think called the Cambridge diet. Don't quote me on that. I had to have that glucose tolerance test to make sure, because they wouldn't start me on that medication. I told the other group this was, people were being licensed to treat this, but they had to go through a series of steps. So this wasn't even my regular internist, but I tried. It was very good. It's not easy to stay on some of the things. Now the low carbs and ketogenic and those kinds of diets are a lot easier because we have so many keto-friendly products. It was impossible. We were making all our own bread and rolls and stuff like that with vital wheat gluten and brewer's yeast and also, oh God. Hey, that's what you do. Before the lockdown, I went from 237 to 177 about a year. And a year ago, this January, I was about, I just looked at the blood test, January 10th. I started 2 weeks later, and I went from about 230 down to about 180. So I lost a different part of 50 pounds. I'm about 187 right now. Girlish figure. Or too girlish figure. My wife is threatening me if I gain it again. I take that seriously. So what happens, we have this. So in diabetes, the carbs can't enter the cells. That's the problem. They're still out there. So you have high hyperglycemia or high blood glucose. So why are tissues being wasted? You use the fats, then you start to use the proteins. You're made out of those things. So the weight doesn't necessarily decline because a lot of times people are still craving these things. They crave carbohydrates. So their weight, they keep eating. Okay. We see that in type 1, maybe a little bit more than type 2. Type 2, the weight definitely doesn't decline. But these are the kinds of things. Poor wound healing. Again, you're going to see that ultimately, you're going to see that there's a lot of suggestions that a lot of diabetes aspects are autoimmune in nature. If your immune system is compromised, you don't heal well. There's a lot of things there. And so let me explain to you kind of what goes on what they're talking about here. So if your blood sugar in a diabetic, particularly before they're diagnosed, it will go up to over 185. Let's say it's around 200. Once it gets past 185, it spills into the urine. That means the sugar over that number, we call it the transport maximum. We learn about this in kidney. That's as much as it can reclaim. Anything over it goes into the urine. When it goes into the urine, just like sodium, water follows it. So now you end up urinating more, and you're urinating a fair amount, and there's a lot of sugar that you're urinating out as well. That's why they call it sugar diabetes as opposed to salt diabetes, where the urine is salty. The longer it's at that level or above, in other words, not being taken care of, that maximum begins to go down. So brittle diabetics, what starts to happen is effectively you're damaging the transport maximum, which are a series of transport mechanisms, little transport protein channels in your kidney that are all over. As they're being damaged, you're beginning to lower kidney function. So now it's no longer 185, it's 175, it's 160. That's why the Joslin Clinic wanted aggressive control early to prevent that. So they wouldn't have kidney failure. They wouldn't require transplantation early. They wouldn't be on on dialysis. All of those kinds of things. And it limited the likelihood of the heart complications, the nerve, the eye complications. So what happens, that's called glycose urine. You're spilling sugar into the urine. And so what happens is you urinate. When you urinate more, you're losing fluid. Thirsty. Your body's not getting its primary source of sustenance as by design, so you are more hungry. So you eat more. So you have polyuria, polydipsia, means thirsty, polyphagia, hungry. And because you can't do the energy transformations with the carbs, fatigue is higher. You still mentioned enough ATP. You get ketogenic, you have enough carbohydrates to kind of keep the system, and you're doing this, you're doing it methodically. So there's numbers if you're really on strict keto and low carb rather than modified. You can measure it, you have to test it, all that kind of good stuff. That's there. Like I said, nowadays it's a little easier because there's so many friendly products. But it's up to you guys if you want to do that. And really, for young people, the time is now, because trust me, as you get older, it's pain in the ass. It's very hard to change habits like that. I'm guilty. We got the pizza last night for the game. Terrible game, but we got the pizza. It's good. Like 5 different times. And we didn't have to get the breadsticks with it, but we did. And the big giant 2-liter Coke. No, we didn't have to do it, but we did. It's a game. It's good. So years ago, they used to call this juvenile or insulin dependent, and that was true. But we know now that this happens. Why it happens, we do not. We know it's an autoimmune disease. Why? Because they produce consistently, we see lumps of protein in the kidney. When they were examined, we didn't know what they were. We had a name for it. It's got a fancy name you don't have to know, called Kimmel-Style-Wilson disease. Diabetics with high blood pressure and had this in their kidneys, we knew they were in trouble. These protein deposits, when they were analyzed, modern technology, were found to be what we call antibody-antigen complexes. We're going to learn about that when we study the immune system here. It's one of the things we see in people with a really nasty immune disease called systemic lupus erythematosus. The second most common after rheumatoid arthritis. They get these lumps everywhere, particularly in their kidney. If diabetes is the number 1 cause of dialysis and kidney transplant, lupus is number 2. Just give you some numbers. So that basically said, this is autoimmune. Where it came from, we're not sure. Was it a virus? Not sure. But something is destroying those pancreatic cells. So, and I think the number is higher than this, but I'm not going to ask you about the number. That's me. Type 2, the one we worry about, used to be maturity onset. Theoretically, this is the vast majority. I don't know if it's that vast. I think, again, that's a little too broad brush. For some reason, I think it's more than just the insulin. I think there's aspects of the insulin, but effectively, it's not getting the job. It's not triggering those receptors. So a lot of us think the problem is receptor oriented. And typically, type 1, we gave them insulin. Type 2, we used oral medications. For years, the oral medications were bad. Now we're seeing dramatic improvement. We're still seeing people with type 2 that we have to supplement with insulin. So there's a lot of overlap, I think. I know nothing about the whole Ozempic and all that stuff. Hey, everybody prayed that people who were overweight, can I just take a pill and get skinny and not to work? Maybe this is it. I don't know enough about it. Inevitably, 10, 20 years, we find out, all of a sudden there's a study, X number of people taking a certain medications now have some terrible side effect or whatever. You learn that nothing is a panacea. Fancy word was my dad used to say there's no free lunch. So hopefully you're wrong about this, but we've had a lot of good medications that we really don't see the ramifications till long-term studies 10, 20, 30 years after the fact. What it's done, maybe what it does to the next generation, particularly if these people have childbearing, we don't know. I'm not suggesting there anything here. It's just my spin on things. And so this is true. And is it? I don't think it's milder at all. Not that other syndrome. Insulin nowadays, it's almost all human insulin because you don't have any problem with allergies that are there. A lot of people, that was my grandfather, didn't want to use it for religious reasons, depending on their religious background. There's many religions that don't want pork products. He didn't want to take the shots. I also, my mom tells me, I have a very vague remembrance. She died in 1955. I was 4. And cattle, which is when I went to school and first started to practice. This was 1977. This came out. I got my doctorate in 1977. Okay. And insulin, if you wonder why we have to use injections, and pumps are very effective or aerosolized, it would be deactivated by stomach acid. A lot of things that we have to take parenterally is the fancy term. Para means next to, enteral means GI. So, or the enteric tract, some other way other than swallowed. Skin patches, skin patches work very well for a lot of things. Nicotine, just a good example. Seasickness pill, tabs, pain medicines, some heart medicines are used that way. Nitrile paste. Unaware, I don't know enough about that to tell you about it. And here, diet, exercise. Yes, there are medications. I wouldn't go so far. First, you do lifestyle changes before you got somebody into gastric bypass surgery. That's a little crazy. All these, I had in the early days of gastric bypass, there were so many criteria. I had patients who got really. I don't recall losing anybody, but some people were messed up, and it didn't work. Terrible. There's all sorts of, basically, they call it stomach stapling. If you don't do it right, I've had my stomach, if you did not know, half my stomach removed twice. Nothing to do with that, all with ulcers. Okay, it stretches. I can't eat as much, but it didn't stop me from having the pizza. Sorry. Oh, looks good too. Oh, I'm sorry. Stuff you've seen. Alphas and betas are important. Remember, alpha for the glucagon, beta cells for the insulin. That's important. That's not. Yeah. How does it work? Liver breaks down glycogen, and basically that glycogen is the only way we store carbohydrates long term. Other than that, if you don't utilize the energy from carbohydrate meals within about a minute, it starts to become fat. That's the problem. Okay, that's here is the wrinkle. And in our diet, most people, their diet is somewhere approaching 50% or more carbs. A lot, maybe 5 to 10% simple, and those complex carbs, pastas and breads and things like that. I mean, it would be a lot easier if we had it balanced out a little bit more. So there's been a lot of misinformation dietarily. I'm not a nutritionist, don't take my word, but there's a lot of good video resources out there that you can really understand what was behind this. A lot of people have really been helped by this. Okay, so what they're doing is they're forming sugar from other sources, not just carbohydrates. They're breaking down the stores, even though it's your emergency store, because they'll replenish it and forming it from other things. That's called gluconeogenesis from new sources. Don't do that. Insulin is secreted in an active form, and then it's activated, does a ton of stuff. Okay, again, glucose as an energy source to do all sorts of stuff. It's the best way to understand it. It's very active metabolically, repair, cellular mechanisms, overall. And again, there's like a tug of war. When insulin's busy, growth hormone is not. Growth hormone is busy, insulin is not. So this is the idea. It plays such an important role in other things. My advanced students, we talk about the enzyme system called tyrosine kinase and all the different things that it does. Okay. And this is the problem down the road with excessive glucose. It converts it. We store it that way. We've got to have some. There's normal amounts of fat. The trouble is, and that's why, however you do it, hello, just I should exercise a lot more. I try to be relatively active for my not so advanced age. Okay, but the reality is I'm not active enough. But you have to marry the amount of carbs calories in, calories out. You want to lose, take less in, or do more to however you want to utilize them. I wouldn't recommend it being strictly a candy bar diet, though. I'm interested. Hey, this me. Okay, it's over by our buddy's house. He's one of those guys who always has like 6,000 candy dishes out when he has company over. So and I snitched a couple of those mini Twix bars. You know why? I'm sorry. He did. He could run out of mounds. It's very upsetting. I love those things. Okay. Here's the diabetes. So they address it as secretion. It's not all that. And is it activity? No, I think it's the receptors. I mean, it's too broad of a brush. We went over all of these things. Here's the problem with these excessive fats and the danger they cause. So your rapid breathing, all of that acidity. If you know nothing else, you know how sensitive we are to denaturing proteins. What are the two factors? Temperature, pH. This acidity lowers the pH. That's what acidity is. And unfortunately, it starts to shut down enzyme systems. Things just don't work, whether it's oxygen transport. And that's why it can be so rapid. I mean, that same patient I was telling everybody else about, I mean, he didn't take his insulin one morning. All he remembered was, I was pretty sure I got to work, and he woke up in the hospital. And what they did, when they gave him sugar, that's why I say you do it immediately. It's like in the movies. Where am I? Perfectly fine. All the other tests are normal. And they said they found you on the parking lot at your workplace. It's just here you are. It's by the grace of God that didn't happen when he was driving right during school bus hours. That he didn't end up running over somebody or running himself into a tree and dying. I mean, and diabetics do. Oh, I'm in a hurry. I'm late for work. I'll get my insulin. I'll grab something as soon as I get to work. Oh, doesn't work that way. Educate them. So this is the low anxiety nerve. And if you didn't get this, sometimes it just hits all at once, and the next thing you know, that's what happened to him. And I think it happened more than once, and so that's what it's hard. It's easy to say. It's hard to teach. And really, that's pretty much what I have to share with you, other than to try to give you an idea that if you can learn as much as you can about this, you're going to see, because a lot of it, many of you are going to be in positions where you're going to be giving advice to people. Many of you are going to be practitioners on your own. There's a lot. There's an educational component. Like I said, don't be. People don't like to be lectured. They want to be spoken with rather than at. And I find that a lot to be true. Depends on the situation. There's a fine line. Some people want you to tell them what to do, and other people don't like that. And that's a feel that you get over years and years. I was very fortunate. For some reason, and it follows me. Maybe you can tell. People find me relatively easy to talk to because I'm very non-judgmental about things like that. So I try to reason with them. It's more of like they'll do as I say, not as I do type of thing. To understand, I've been down that road, particularly with that. Fortunately, not having the diabetes, but suffering from a lot of the problems that were part of it. So, I think that's part of why we all have to know so much about it. So there's not nearly as much on the test as what I have shared with you today. And that's kind of why I gave an introductory lecture that I sent with those YouTubes for when I'm away. And you got the instructions. Like I said, you're doing this on Valentine's Day. Sometime when you're doing this, I'll be at a wedding where I'm going to have to be involved. So My wife's trying to convince me not to take my computer. And I can just imagine what would happen if this went off. Somebody's trying to contact me. Normally, when I do Blackboard exams, I give you my phone number and say, contact me. Don't bother. I'm not going to be, because I would be. My daughter's already texting me every day. That's the nervousness index is going up dramatically. Thank you very much. Have a wonderful rest of your day. See you all basically same time next week. Sounds like a TV show. Stop recording.